Laparoscopic surgery is a minimally invasive procedure commonly used to treat diseases of the gastrointestinal tract. Though many digestive problems can be treated successfully with lifestyle changes or medications, some conditions may require laparoscopic surgery. To know more on laparoscopic gastrointestinal surgery, we have with us today Dr. J.K.A. Jamil, surgical gastroenterologist and minimal access surgeon at Apollo Main Hospital, Greens Road, Chennai. Morning, doctor.
Good morning. Greetings to you.
What is laparoscopy, doctor?
Laparoscopy is a technique within the field of surgery wherein the surgeon makes small holes in the abdomen to perform the procedure as opposed to making a big cut. So the actual operation itself that the surgeon does inside the abdomen is the same. It's just the access route which is different. It's a sort of a minimally access way of performing the operation inside the abdomen.
How is it performed, doctor?
Well, as I said, it is by making small holes inside the abdomen. These patients have to have a general anesthetic. After they've gone to sleep under general anesthetic, the surgeon makes small cuts, usually about 5 millimeters or 10 millimeters. And through those small cuts, the surgeon inserts tubes, either metal tubes or plastic tubes, which act as guides for him or her to pass the instruments, which we call as laparoscopic instruments. So these are fairly long instruments, slender instruments, and through those instruments, we perform the operation. The vision is brought from the inside of the abdominal cavity to the surgeon's eye through cables that get connected to a video camera, which is relayed to a television monitor. So it's a very novel way of doing the operation. And as I said, the beauty about it is the minimally invasive nature of it. So something that was previously being done by making a big cut and by the surgeon putting his entire hands and fingers inside the abdomen is now being achieved by making just small holes.
So by minimally invasive, you mean the amount of scar is reduced in the body?
That's right. Yeah, that's one part of it. But the actual term minimal access and minimally invasiveness is actually quite a broad term. It is not just about the holes, but it's also the fact that there is a reduced amount of disruption that happens inside the abdominal cavity. And when there is a decreased amount of scarring and disruption in the abdominal cavity, the overall experience that the patient gets following surgery is much better. The most important thing is the pain. If you can imagine the pain that comes from 3 or 4 holes of 5 millimeters or 10 millimeters sizes in comparison to the pain that comes from a cut which is about 15 centimeters. There's a huge difference between the two. And because the pain is less, there are a number of other problems also that are reduced in the postoperative period in patients who have had laparoscopic surgery. The most important of which is what in medical terms we call as pulmonary complications. When somebody has a cut in the abdomen, the pain from that big cut causes splinting of the diaphragm, which is the muscle that separates the chest from the abdomen. And as a result, the patients don't breathe well. They don't breathe well in the postoperative period, and that can cause lung complications. With laparoscopic surgery, it has been documented and it's been published extensively worldwide that the amount of pulmonary complications is much less. Furthermore, because the scars, because the wounds are small, the incidence of wound-related problems are also less. Wound-related problems such as wound infections, incisional hernias are less. From the point of view of mobilization and getting back to normal activity and getting back to work, again, there's a huge difference between patients who have had laparoscopic surgery and the ones who have had open surgery. Most of the patients are able to get out of the bed and walk to the toilet in about 6 hours time after laparoscopic surgery. And that's a big advantage, particularly in people who have to get back to work early. And therefore, time and again, we hear stories about patients who have had laparoscopic surgery on a Monday and have gone back to their work on Wednesday or Thursday. So it's great news for the patient, early recovery. And it's got good financial implications as well, simply because, when you're when you're in the hospital less and when you're off your work more, obviously it's going to have financial implications on you and your family. So these are all some of the benefits that laparoscopic surgery has given to the surgical community and to the patients.
And does it require for the patient to go under general anesthesia, doctor?
Almost all the time, yes. There are very, very exceptional cases where we do attempt laparoscopic work without giving a general anesthetic. But then for all practical purposes, at least for the benefit of the audience today, one has to understand that a laparoscopic surgery requires a general anesthetic. Obviously, it's beyond the scope of this program for us to go into the details of what those exceptional circumstances could be.
Apart from, as you mentioned, apart from less scarring and quicker getting back to normalization, what are the advantages of undergoing a laparoscopic surgery?
Well, those are the main things, as I said. There's when patients get back on their feet and get back to their normal routine quicker in lives, it has an overall effect. It has lots of physical effects and psychological effects. Physical effects, I mean, I'm sure all of you are aware there's a condition called deep vein thrombosis, where the blood clots in the veins of the leg. And one of the most recognized predisposing factor for deep vein thrombosis is immobilization. So somebody who's on the bed after major surgery has not got out of the bed, has stasis of venous circulation, and that gives rise to deep vein thrombosis. And deep vein thrombosis can sometimes be quite dangerous, especially if the clot detaches from the leg and goes to the lungs. Now, as we said a little while ago, patients who have had laparoscopic surgery, they get out and walk within 6 hours, within 8 hours, or at the latest the following day. So the chances of them developing these kind of immobility-related complications are less. So that's the physical side of it. I mean, from the psychological point of view, well, it's always a great feeling to get out of the hospital quickly, and you'd be surprised. Sometimes patients who haven't got much knowledge about laparoscopic surgery, and it's quite understandable that they don't know much about it, they get surprised when the surgeon tells them, look, you're going to have the operation in the morning and you're going to be walking out of the hospital in the evening. It just doesn't get to them that easily, but that's the reality. Simple procedures. I mean, the laparoscopic gallbladders, for example, laparoscopic cholecystectomies, or laparoscopic hernia repairs in young fit patients. Most of these operations these days are done worldwide as well as in India as daycare procedures. So it gives a great feeling of well-being for the patient too, to be back in their own house, sleeping in their own beds the night after surgery.
Can laparoscopic surgery be done for cancer as a part of cancer treatment, doctor?
Certainly. I mean, as I told you right at the beginning, it's a technique. It's a technique in the field of surgery. It can be done for any kind of operation within the abdomen. Now, if I have to go back on history a bit, see, the gastrointestinal surgeons and general surgeons started doing laparoscopic surgery in the late 80s. And when they started off, they started off with simple operations like laparoscopic cholecystectomies, diagnostic laparoscopies, laparoscopic appendicectomies, and then slowly the skill set of the surgeons worldwide improved, and they expanded that to laparoscopic inguinal hernia surgery, and then to bowel surgery, colon surgery, gastric surgery, and then since the sort of early 90s onwards, there has been an exponential rise in the number of laparoscopic surgeries done worldwide, and that includes surgeries for gastrointestinal cancers as well. You find lots of information in the world literature now about laparoscopic cancer surgery for colon cancer, for stomach cancer, for pancreatic cancer. So basically, the pickup of this particular technique has been phenomenal, and now, well, 2019, we could safely say that almost all, if not all, gastrointestinal procedures have been done safely, have been attempted, and have been done safely by laparoscopic surgeons worldwide.
Can all patients undergo surgery laparoscopically? If not, what do you do if you cannot perform the surgery laparoscopically on a patient?
You see, that's a very good question. Can all patients undergo laparoscopic surgery? The answer is no. That's a decision that has to be made by the surgeon in conjunction with the anesthetist. Okay, there are specific group of patients who may not be fit for laparoscopic procedures. Their body may not be strong enough to sustain the rigors of laparoscopic surgery. As in, when I say rigors, what I mean is we put in a lot of carbon dioxide inside the peritoneal cavity, inside the abdominal cavity to do this operation. Some patients may not have the capacity to take it. And we do explain to the patient, well, laparoscopic surgery is great. However, in your particular situation, it may be better that we go straight for an open procedure. That's one category of patients. There's another category of patients who may have severe problems with their heart or their lungs, which again will make a general anesthesia quite difficult, or sometimes even impossible. Now, as you know, I mean, operations in the abdomen can be done under general anesthesia, and they can also be done under spinal anesthesia. So when we have a patient who definitely requires an operation, but he or she may not be fit for a general anesthetic, and that's the anesthetist telling you that, you can't turn away that patient because obviously he needs that doing. So you go for the spinal anesthetic. But then the issue we have with spinal anesthetic is, as I told you before, laparoscopic surgery is not possible. So such patients, we tell them, sorry, sir, or sorry, madam, we think it's safer, it's better for you to have this operation done under spinal anesthetic as an open procedure. So there are, there's always exceptions, and this is why it's important that patients have a full and a frank discussion with the doctors, I mean, with the surgeon and the anesthetist, because it's not like, one size fits all. What applies to person A or patient A may not apply to patient B. With regards to the second part of your question, what happens what happens if laparoscopic surgery cannot be done? Is that right? I mean, what happens if the surgery cannot be accomplished laparoscopically?
Yes.
Yeah. So that is also something that we, as surgeons, we have to explain to the patients. Every operation that is attempted laparoscopically, or it is going to be done laparoscopically, it is a duty of the surgeon to inform, to counsel the patient that should laparoscopy not be possible, and that's something that the surgeon will get to know at the time of surgery, when the patient is on the operating table in the operating room. We will convert the operation from a laparoscopic procedure to an open procedure. So that's something that has to be informed to all the patients and documented in the consent form, and the patient should be aware. It's very important, simply because if there are any particular issues that arise during laparoscopic surgery, surgical issues, again, it's difficult for us to go into the details of all of this in a program like this. If there are any technical issues, problems that get encountered during laparoscopic surgery, the standard teaching is, this is what we teach our junior surgeons who come to us to get trained in laparoscopic surgery. The standard teaching is, put the patient's safety first, do not carry on laparoscopically, convert it to open, and complete the job safely. That's the slogan, that's the message that needs to go across. And we teach this to our juniors, and it's important that we convey this message to the patients. This is the methodology we adopt, because more important than having a patient with an operation which was done laparoscopically, it's important that we have a patient who has got no complications, even if it means conversion of surgery from laparoscopic to open. So therefore, that is something that needs to be explained quite clearly. And the other important thing that we mention in almost all these surgical conferences, and we pass this message on to our juniors, is that conversion of surgery from laparoscopic to open on the operating table should not be deemed as a failure on the part of the surgeon. It's a decision that the surgeon makes on table in the interest of patient safety. Obviously, the possibility or the percentage of conversion to open from laparoscopy to open goes down as the expertise of the surgeon goes up. The more experienced laparoscopic surgeon you are, the less likely you are to end up with problems and convert it to an open procedure. But then it's never zero. It can happen to anybody at any time, and therefore that's really important that surgeons are aware of this, and this message gets across to the patient community too.
What are the procedures that are more commonly performed laparoscopically, doctor?
As I said, almost all the procedures inside the gastrointestinal tract can be done laparoscopically. But from the point of view of common operations, laparoscopic hernia repairs, laparoscopic appendicectomies for people who come with acute appendicitis, laparoscopic cholecystectomy, which is basically an operation to remove the gallbladder when the gallbladder develops problems from stones, inflammation, and so on. And then a procedure called diagnostic laparoscopy, which is something that we do on a regular basis. These are procedures done to find out, to establish a diagnosis when things are a bit unclear from all the non-invasive investigations that we have done for the patient. So those are the common ones. But then, as I mentioned before, we do laparoscopic gastrectomies, laparoscopic colectomies, and almost every organ in the peritoneal cavity has been operated upon successfully worldwide laparoscopically.
You mentioned about diagnostic laparoscopy.
Yeah.
Could you please elaborate on that?
Okay, sure. See, as the name suggests, it is an operation that we do to establish a diagnosis. right? It's called diagnostic laparoscopy. Okay, going into the grammar of it, the technicalities of it. Diagnostic is because we haven't had a diagnosis on the patient as yet. The patient must have had blood tests, ultrasound scans, perhaps CT scans, maybe endoscopies, colonoscopies. Yet the doctors are unable to find out exactly what the problem is inside the abdomen. So we have to do a procedure inside to establish the diagnosis. That's the diagnostic part of diagnostic laparoscopy. With regards to laparoscopy, I mean, we've talked about it last few minutes, but then going again to the technical aspect of it, it's a minimally invasive procedure. It's a generic term. Minimally invasive procedure is a generic term. When it is done in the abdomen, it is called laparoscopy. When the same minimally invasive or minimal access procedure is done in the chest or in the thorax, it is called thoracoscopy. When it is done in the joints, it is called arthroscopy. So you can see the link there. You know, it's the same sort of concept applied to different parts of the body. So when you do this in the abdomen to find out a diagnosis, we call it diagnostic laparoscopy. So the same technique. I mean, general anesthesia, patient comes in the morning, and most of these diagnostic laparoscopies can be done as daycare procedures. So, you know, just to clarify, daycare procedure meaning the patient comes to the hospital at 7 in the morning. Most of the time it's around 6:30, 7 in the morning. After a period of overnight fast, we get them done in the first half of the day. They stay in the hospital for about 4 or 6 hours after that, and they're home by 6 p.m., 8 p.m. maximum. And as I said, they just have a few holes in the abdomen for us to introduce the instruments and do the job. Have a bit of pain. Most of the time, the pain is well controlled with paracetamol tablets. And we take biopsies too in diagnostic laparoscopy. So if we find something that wasn't detected earlier in any of the previous tests, we take biopsies. Biopsy result comes back in about 3-4 days time, and then the diagnosis is established.
So based on the diagnosis of the diagnostic laparoscopy, we come to a conclusion whether the patient requires a treatment in terms of medications, or will he have to go back to surgery?
Absolutely, yeah, that's a very important answer that we get from the diagnostic laparoscopy. You know, particularly in cancer patients, you know, sometimes we have situations where we aren't sure whether the cancer has spread or not spread, despite all the battery of investigations that the patient has had. And when we put a diagnostic lab, when we put the laparoscope in, when we assess inside, we may be able to detect small areas of spread within the peritoneal cavity, which was not detected in any of the previous investigations. And that has a huge bearing on the management, on the treatment process, because if there is a spread, it's very likely that the patient will not require further surgery. The patient will go on to have something else, possibly chemotherapy. But if there is no spread, these patients are brought back in on another day to have the planned surgery. So it is a very important tool in the patient management pathway.
What should one expect from the recovery period during or after a laparoscopic surgery, doctor?
Okay, recovery. Let's talk about the common operations. Okay, because the recovery period obviously varies depending on the type of operation we do. If I were to just take a common example like a laparoscopic cholecystectomy, the operation usually lasts about half an hour to 45 minutes. And I mean, this is just talking in broad sense, right? I mean, there are always exceptions, and medicine, as you know, doesn't follow strict rules. There are always exceptions, and the treatment has to be tailored according to the needs. But we're just talking in broad terms. An operation for the gallbladder requiring probably around half an hour. Patient is out of the anesthetic and completely awake in the next half an hour, and they stay in the recovery for a couple of hours. So So that's basically in the operating chamber for about 3-4 hours. And then they are in a room called recovery room, where they're monitored for how well their pulses and blood pressure is, and so on and so forth. And one of the main tests that the nurse in the recovery room does after these kind of operations is that they get the patient out of the bed. It might sound very simple, but it's a very important test, a very useful test to find out if the patient is all right or not all right. A decision, whether the patient can go home or not go home. So they get the patient out of the bed and they get them to walk. And then they check if the patient has been to pass urine, they've been to the toilet independently, and if their pulse and blood pressure and everything is okay. And these are all some of the things that they use to decide whether the patient is well enough to be discharged. And if they tick all the right boxes, they're out of the hospital in 6 hours' time. Recovery after that, well, as I told you before, a few paracetamol tablets is all that should be required for them to remain comfortable and pain-free. And usually that's only for a few days, 2 or 3 days, no more than 3 days, unless they have other problems. But straightforward operations, usually 3 days analgesia should be sufficient. And the only advice I would give these patients is, they're back to their normal diet, by the way. There's no dietary restriction as such after these kind of simple and straightforward laparoscopic procedures. Whatever they were eating before surgery, they're allowed to eat from the next day onwards. The only thing that I would tell them is, in terms of restriction, is do not lift anything heavy. Heavy weight lifting, simply because we put a stitch to close the hole, usually at the level of the belly button. Although it's a hole, it is a 10 millimeter hole, and we put a stitch to close it. We would hope that the patient would not do anything strenuous for a few weeks, so that the hole heals well and the stitch dissolves well. If they do too much of activity too soon, there's a small possibility that single stitch might give way and they can develop what is called a port site hernia. So that's the only restriction. Apart from that, they can they can lead a normal life. They're independent, going to the toilet, they eat normal food. If they are at a desk job, they are perfectly all right to go back to their desk job within 3 to 5 days. And there's no need to remain on any long-term medications.
We've got a number of questions on what you answered, doctor. How long do I have to stay in the hospital? How soon can I start eating normal food?
Oh, okay.
And when can I get back to work? You answered all of it. And there's one question on how long should I take absolute bed rest?
Answer is 0. There is nothing like bed rest, right? It's a very valid, it's a very pertinent question, because patients do ask these questions in the consulting room. Doctor, should I be in bed? The answer is no. I don't want you to be in bed. I want you to get up and walk in 6 hours' time. The earlier you mobilize, the more active you are after surgery, obviously within the bounds of what you can do. We're not expecting you to run a marathon in 3 days' time, but certainly you will be able to get out and walk. You will be able to move around within your house quite comfortably. You will be able to use the toilet independently. You would be able to do all of these, and you have to do all of these. If you don't do these, and if you confine yourself to the bed, obviously you're not doing yourself a favor.
We have a question. What is the special care that I have to take after a gallbladder removal? This is not pertaining to laparoscopy.
Well, I guess they're asking this question from the point of view of laparoscopic gallbladder removal or laparoscopic cholecystectomy. I'm not too sure what exactly is in their minds, but I guess it has got to do with diet, or perhaps getting back to work. If that's the case, I think we've already answered that question. But then if I may rephrase that question, because patients do ask me this question on a regular basis, will my digestion be okay after a gallbladder removal? I'm not sure if that is what that patient meant, or that person meant. You see, the gallbladder is a storage organ, and there is a misconception that gallbladder secretes bile among the general public. It doesn't. It is, as I said, it is a misconception. The bile is secreted by the liver. The bile secreted by the liver gets stored in the gallbladder and then gets sent to the bowel in a pulsatile fashion, periodic fashion throughout the day, depending on your timing of meals and the quantity of meals, quality of meals, and so on. By having your gallbladder removed for a valid reason, you may have had pain, you may have had fever, you may have had jaundice, whatever. By having that gallbladder removed, you are not depriving yourself of the bile quantity that is getting secreted and going into your gut, because it comes from the liver and goes into the duct. It's just the storage part of it that you will end up losing. Would that have a serious consequence on your digestion? No. No is the answer. Not for the vast majority of people. Occasionally, there are some patients who have a bit of increased frequency of stools after a gallbladder removal operation, and that can also be rectified by certain medications, and it usually that problem lasts for a few months, and after that they are also back to their normal. And that is attributed to the increased frequencies. We talk about it a lot in conferences, and we believe it is because the pulsatile flow of bile from the gallbladder, that aspect of it is gone because of the removal of the gallbladder, and the bile flows more continuously into the bowel, and that's what causes the increased frequency of bowels. As I said, it is not a regular occurrence. It happens occasionally, but there are ways and means by which that can also be sorted out.
Will laparoscopy work in revision surgeries, doctor?
Yes, it would certainly work. It depends on the expertise of the surgeon. Way back in the late 80s or early 90s, previous abdominal surgery was regarded as a contraindication for laparoscopic surgery. By which what I mean is, if the patient has had an open surgery before, the surgeon should not attempt a laparoscopic surgery. But this was the teaching in the early phase of laparoscopic surgery. We're talking about 30 years ago, but that's completely changed now. As I said, the expertise of surgeons in laparoscopic work has gone leaps and bounds, and there's been a very healthy advancement in technology. Laparoscopic instruments, energy devices, staplers, and therefore a lot of things that were previously not accomplished laparoscopically are being accomplished now. So the answer to your question, even if there has been previous abdominal surgeries, laparoscopic surgery can be attempted, and it has been attempted, and it has been successfully done. But with the caveat, largely dependent on the expertise of the surgeon.
What are the advantages of obese patients undergoing laparoscopic procedures in particular?
Plenty. Obese people are at increased risk of respiratory problems after any abdominal surgery, and that incidence is reduced because we are making small cuts as opposed to a big cut, and the diaphragmatic movement is better, and therefore respiratory problems are less. Number two, obese patients, obviously there's a lot of fat there's a lot of fat in the abdominal wall. So for those of you who are not aware, there's a skin in the abdomen, and below that there's a fat layer, and then there's a muscle layer. Your muscle can be, can be bulky. It's good for you. That's not a problem. But then if the bulk of your abdominal, I mean, we call this as abdominal wall. Skin, fat, muscle layer together is called abdominal wall. Your muscle can be bulky, but if the bulk of your abdominal wall comes from that fat layer, it's not good for you. It's not good for you, and that's what obese people have. So when obese patients have a big cut, you end up exposing the entire fat to the outside environment. Obviously, we close it back, but then there's always that increased risk of infection in that big fatty layer. So if the same operation could have got accomplished by making small holes, that risk is less. Which is why, if you remember earlier on in my talk, I did say there's a reduced risk of wound infection with laparoscopic surgery, and there's a reduced risk of incisional hernia with laparoscopic surgery, because an infection is likely to lead on to a hernia. If there is an infection in that obese patient, in that fatty layer, that's going to creep into to the sutures, which are below, the sutures that are holding the muscles. And over a period of time, those sutures could also get into problems, and the wound healing may not be very good. And these are the kind of patients who develop what is called an incisional hernia, a hernia that comes up in the incision. And they develop, I mean, the primary problem for which they had the operation is not there anymore, but then they are now having to put up with a new problem, which is an incisional hernia. Not in all cases, as I said, perhaps in about 5% at least, there is a risk of incisional hernia after laparotomies for obese people.
What would be your message for our viewers today, Doctor?
Well, message is laparoscopic surgery is a boon, is a gift for the patient community, and surgeons all around the world have become increasingly experienced in this new technique for the benefit of the patients, and that is well reflected in the exponential increase in the laparoscopic work that has been done all over the world. However, patients should be aware that there are situations where laparoscopic surgery may not be appropriate or may be difficult, and the surgeon may have to convert the procedure to an open procedure. So that is perfectly acceptable, and it should not be regarded as a failure. The important thing is the job inside the abdominal cavity needs to be done, and if it can be done with this new technique to patients, the results are fantastic, and there's enough literature, enough papers in the medical literature worldwide to substantiate this.
Thank you very much, Doctor, for a very elaborate and informative session. For appointments with Dr. J.K.A. Jamil, surgical gastroenterologist and minimal access surgeon at Apollo Main Hospital's Greens Road, Chennai, you may reach out to 98416 51004. I repeat, 98416 51004. Thank you, Doctor.
Thank you very much for the interaction, and thank you all the viewers for the session.